Welcome, ladies and gentlemen. Thanks for joining this lecture, Occlusion in Fixed and Removable Prosthodontics. The Part 1 and Part 2 lectures outline our evolution and philosophies of occlusion, treatment planning using conformative and reorganized approach in fixed and removable prosthodontics. Let's start. This diagram represents the evolution of occlusion, from Becker and Kaiser, 1993. As we know, all occlusal concepts are based in part on theory, and all of these theories borrow in part from the past. Therefore, it is good to know their interrelationships, where they agree, and where each concept contributed to our ongoing understanding of occlusion. There are various occlusion concepts in dentistry. The most commonly adopted one are gnethology and Pankey-Mann-Schuyler. The Gnethological Society of California was founded in 1926 by Dr. McCullum and 15 of his associates, while Pankey started his work since 1928. All current occlusal concepts are based, in part, on theory, and all theories may have borrowed from the past. Therefore, when studying modern concepts of occlusion, one should consider how current principles evolved. The gnethology group found that this occlusal scheme was very favorable initially. Patients were comfortable and their restorations functioned in the mouth just as they had on the articulator in the lab. However, there was no longer a coincidence of maximum intercostal position and centric relation. They found that uneven wear had caused the balancing side contacts to become heavier than the working side and therefore traumatogenic. The main features of this occlusal scheme can be divided into two categories: centric and eccentric relationships. The maximum intercuspal position of the teeth shall occur with the jaw in centric relation. The posterior teeth shall make even simultaneous contact and the anterior teeth shall remain slightly just out of contact in maximum intercostal position. Cusp to fossa scheme and tripartization should be applied in this concept. Immediate disclusion of the posterior teeth provided by the overlap of the maxillary cuspid in lateral movement and immediate disclusion of the posterior teeth provided by the overlap of the maxillary incisors in a protrusive movement. The group function concept has developed from the concept of bilateral balanced occlusion. The main justification of this occlusal scheme is that a certain amount of lateral stress on posterior teeth in function provides needed periodontal stimulation and distributed occlusal loading over a number of teeth. The main characteristics of this concept are listed here. There are two ways to plan for patient occlusion: the conformative and reorganized approach. We must try to adopt the conformative approach because it is the safest way to treat the patients. The conformative approach is defined as the provision of restorations in harmony with the existing jaw relationship and without changing the occlusal vertical dimension. All the indications are listed here, such as single or small number of direct and indirect restorations. These are some of the cases that are indicated for conformative approach, such as for removable partial denture, single conventional bridge, two veneers and single tooth implant. The reorganized approach is to develop a new occlusal scheme in the centric relation. This approach is to provide an occlusion that is ideal to tooth, system and patient level. This slide has also explained some of the indications. These four cases are indicated for reorganized approach, including localized tooth wear, fully edentulous, amelogenesis imperfecta and partially edentulous case with inadequate restorative space. Some pre-restorative occlusal management works are needed prior to a reorganized approach to ensure the success of the cases. There are occlusal analysis, occlusal adjustment to remove some occlusal interferences, trial preparation on study casts prior to do it clinically, diagnostic wax up whether to increase the vertical dimension, and occlusal splint for some cases. With regards to occlusal analysis, Facebook transfer and interocclusal record at centric relation are taken. The study casts are mounted on semi-adjustable articulator for most of the cases. The importances of the mounted study casts are listed here. It is advisable to manipulate patient's jaw into centric relation based on a difficulty. For those easy patients, we can manipulate the jaw manually. For more difficult patients, Lucia jig or occlusal splint can be used to deprogram the muscles prior to the jaw relationship record. It is advisable to use an average value facebow to relate the terminal hinge axis to the maxilla, and transfer to the semi-adjustable articulator. This is a general guide regarding how to increase the vertical dimension using semi-adjustable articulator. For trial occlusal adjustment, better to perform it on the study cast. We can paint the occlusal surfaces into red to see clearly the damage on the teeth after the adjustment. Then only decide whether to perform it clinically or find the alternatives. Once we have analyzed patients' extra and intraoral conditions, then only start to perform the diagnostic wax-up on the mounted casts. We can perform the diagnostic try-in using the wax-up as a guide in a later stage. There are some cases need to prescribe stabilization splint prior to the centric relation-jaw relationship record. The author recommended the hard splint type. These are the justifications to use the stabilization splint for some cases. For example, deprogramming the muscles to identify the centric relation, diagnostic purpose such as bruxism, to protect the teeth and restorations, to treat bruxism and temporomandibular disorder, and to check the adaptation of the new OVD. The author recommend the prescription of the stabilization splint as stated here. First, adjust the splint to create an ideal occlusion, create a flat occlusal platform to allow repositioning, instruct patient to wear at day and night and review after 2 weeks' time. Once you have confirmed the centric relation, only take the jaw relationship record. For fixed prosthodontics reorganized approach, we have to manipulate the patient's jaw into centric relation and plan for an ideal protrusive and lateral guidance. This slide has showed you the recommended posterior and anterior determinants. We should try to plan this occlusal scheme for diagnostic wax-up, provisional stage and definitive restorative stage. With regards to the occlusal vertical dimension, there are 3 justifications to increase it. First, to create restorative space such as tooth wear cases. Second, to improve the jaw relationship. Third, to improve the aesthetics. There are various methods to determine the occlusal vertical dimension, including using freeway space such as complete denture cases, trial appliances, transcutaneous electrical neural stimulation, measurement using cemento-enamel junction, the method of facial proportion, and last is using aesthetic morphology or normal tooth dimension. The aim is to have minimal changes of the OVD that allows the minimum dental treatment to satisfy the patient's concerns, aesthetics and functions. To plan for a full mouth rehabilitation case, there is a reorganized approach involving changes of vertical dimension, from preoperative stage to provisional stage. However, once we have finalized the occlusion during the provisional stage, we should apply the conformative approach to the definitive restorations. To copy the anterior determinants, customized incisional table is recommended. This slide is showing the ideal or recommended occlusal scheme at tooth, system and patient level.